my pleasure to invite the next speaker, another brilliant ex-alumnus of Netragama, Dr. KARTHIK SRIPRAKASH, who is currently a consultant, phaco and refractive surgery at Sri Eye Care, Bangalore. And apart from being very hard-working fellow, which he was, he's also very creative. And during his fellowship, he made some great scientific films that won awards at ASCRS, and he also won Best Paper of the Award at AIOC 2018. And today he'll be discussing with us the role of optical quality analyzer, basically for assessing post-op patients' visual quality after refractive surgery.
Thank you for the warm words, ma'am. Always a pleasure. So we've all had this patient after a seemingly uneventful refractive surgery, and you've measured the vision, it's 20/20, but the patient is still unhappy. We've all had that patient. So what exactly is happening? Well, this is the time when we have to start looking at the role of optical quality in refractive surgery. Now, optical quality essentially has two main determinants. The first including aberrations and defocus, that was explained by Dr. Supriya very well. And the second is ocular scatter. Now, there are main areas for ocular scatter and post-refractive surgery eyes, and this scatter leads to retinal stray light. Now, the retinal stray light, it deteriorates the point spread function of the retina in the periphery and leads to these kind of untoward complications and untoward side effects. Now, the HD analyzer is an optical quality assessment system which objectively measures optical quality, and it takes into consideration the effect of aberrations and the loss of ocular transparency. Now, it has its advantages over traditional aberrometers, wherein these traditional aberrometers, they tend to overestimate the potential visual acuity. The HD analyzer uses a double pass system, and this analyzes the retinal image from a point source of light. Now, the first pass is from a 780 nanometer single point source of light laser diode, which goes through a Badal system with a focus corrector which corrects for spherical defocus. The second pass is from the retinal image, which passes through an artificial pupil, which is PA2, into a charge coupled camera device, which is the double pass image. Now, there is also a camera which measures the natural pupillary diameter, and the artificial pupillary diameter can be changed anywhere from 2 millimeters to 7 millimeters, but the machine would take the smaller of the two diameters as the effective pupillary diameter. Now, the double pass retinal intensity PSF image which is obtained is analyzed to give three parameters. The first is the objective scatter index, which is, or the OSI. Now, this is nothing but the objective evaluation of the intraocular scattered light, and the way it's calculated is by calculating the amount of light which is outside the point spread function as compared to the amount of light at the center. A higher value would indicate higher scattering, and the normal OSI of a normal eye would be less than 1. The second is the modulation transfer function, which evaluates the degree of detail that can be distinguished by an optical system, in this case RI, and mathematically it is derived by dividing the contrast of the optical system or the eye by the contrast of the real scene. Maximal allowed MTF is 1, which would mean a perfect optical system. We also know that the contrast reduces as the spatial frequency increases, as we are able to see in the middle diagram there. And at a certain frequency, the contrast becomes 0 or close to 0, and this is called as the MTF cutoff. Now, this MTF cutoff is essentially the highest spatial frequency the eye can detect, and a higher MTF cutoff value would equate to a higher quality of the optical system. The normal eye has a MTF cutoff of about 60 cycles per degree. The third objective parameter is the Strel ratio, which is the ratio between the peak intensity from the PSF of an aberrated eye versus the peak intensity from a non-aberrated eye. A higher value would indicate a better optical quality, and a normal Strel ratio is about 0.3. So the steps of optical quality acquisition is that the first step is we need to determine the manifest refraction, and we need to confirm it to 0.12 diopters. Next, the pupils are dilated so that we can artificially control the diameter through the artificial pupillary aperture. And for optical quality assessment, the ideal artificial pupil diameter should be about 4 millimeters. After we enter the demographic data into the machine, we also enter the manifest refraction, and the machine searches for the best corrected spherical refraction around the determined range, and it can correct anywhere from +5 to -8 diopters, as well as cylinders of less than 0.5 diopters. Anything more than that, it would recommend corrective lenses automatically. The first sequence is the best focus sequence, which is necessary to avoid the blurring of the double pass image, and it's always determined before any other measurement. This searches for the best double pass PSF image by sweeping for different spherical refractions to correct focus. And it also automatically selects this image, which is considered in most focus, with the corresponding refraction displayed below it. The second is the OSI measurement, and this is measured at the best corrected focus and with a artificial pupil of 4 millimeters. 6 double passed images with the best spherical correction are obtained, and green markings indicate that the machine considers that the image quality is good. Once the OSI is captured, the next screen would give you the image view area, which is what we see here, which is basically a convolution of the PSF image with the original image of the scene. It's basically what we see here is a image of a baby at one distance. It basically simulates a daily scene, which represents the effect of aberrations and light diffusion as how the patient is actually seeing. Although it doesn't consider glare and halos, but still it's a very good representation of how the patient is supposed to see versus how the patient is actually seeing. It also displays the OSI numerically and in a color-coded screen, and it also displays the potential visual acuity as we can see it in the right lower corner. The second objective is the MTF display, which can either be displayed in a linear or a logarithmic scale. It also displays the MTF cutoff as well as the strain ratio. The last thing that the HD analyzer can also do is also check our tear film analysis, wherein it captures 40 images at 0.5 second interval with a artificial pupil of 7 millimeters instead of the traditional 4. The point spread function image degradation over time is noted, and even blinks can also be noted, and the degradation the time is started from the time of the last blink. So this gives us a change in objective scatter index with time, which also plots the visual quality index. A newer software update of the HD analyzer also provides the visual breakup time, which is a very important indicator to see how much the dry eye is affecting the vision. Let's look at a few clinical examples. These are routine cases. The first one is a patient who's undergone relaxed smile, uneventful surgery. We're just looking at the evolution of right eye with time. Preoperatively, the OSI is about 0.5 diopters, and postoperatively on day 1, the OSI is 0.4, and about 1 month later, it's about 0.3. Let's look at another case post-PRK. So preoperatively, the OSI is 0.3 in the left eye, and as expected on the 5th postoperative day, there's a significant increase in the OSI with a deterioration in the optical quality. The OSI has gradually settled down by the 15th postoperative day, and by 12th month, it's absolutely normal. Here's another case of an uneventful LASIK. Preoperatively, OSI is 0.3. Postoperatively, at 5th day, the OSI is 1, which is still okay, but it has taken some time to come back to 0.5 at the 1 month follow-up. Let's look at one interesting case where the HD analyzer helped us make a decision to start treatment early. So we had a 35-year-old female who was planned for relaxed smile in both her eyes. The manifest diffraction corrected to with the manifest diffraction, her corrected distance visual acuity in both the eyes was 20/16. Preoperative OSI in the right and left eye was 0.3 and 0.5 respectively. On the postoperative day 1, the patient was seeing 20/20, but she complained of some mild blurring of vision in both the eyes. The vision did not correct beyond 2020 in both the eyes, and on slit lamp examination, some mild interface haze was noted. The anterior segment OCT was inconclusive, so we just repeated the HT analyzer, and we found that the OSI had significantly increased. Almost, it's on the yellow. So what we did is we stepped up the topical steroids, and we asked her to review after 3 days. 3 days later, she says that her blurring of vision has, she feels much better. And corrected distance visual acuity is now 20/16 parts. The interface looks clearer, and the OSI is improved significantly. So we asked her to continue her steroids and then taper it and then review after a month. After a month, she's absolutely happy, and even the OSI is settled. The unaided distance visual acuity is 20/16, and the interface was clear. So we've asked her to continue her post-operative medications as per her chart. So to conclude, the optical quality analysis system is becoming more and more indispensable in the era of very fine refractive surgery. It helps us detect any kind of deteriorating optical quality very early, as we saw in the previous case. It also helps us understand any pre-existing scatter preoperatively. It also helps us evaluate dry eye assessment, and it also gives us temporal data on follow-ups to understand how the scatter is deteriorating or improving. Since it gives us an objective understanding of optical quality without relying on subjective response, it ensures higher repeatability. And to make patients understand how different procedures would give different healing times, it would be a very valuable tool for patient counseling. Thank you so much.